What I want to present today is what to look for in children, what are some possible treatments that we can do, and to understand that the interaction we have with all our specialists as dentists, the most common interaction should be with an ear, nose, and throat doctor. Why? Because here's the palate. We're working below the palate, right? He's working above the palate. But ultimately, the major portal of breathing is through the nose, right? So you've probably gone on social media and realized there's a hell of a lot of information on why mouth breathing is not good, right? So I'm on the ADA Oral Health Committee as well. And every year for Dental Health Week, the same boring message comes up. What is it? You brush, bass technique, floss regularly. None of our patients listen to that message. Who would agree? By saying that there's more chance of tooth decay, right? Well, it's certainly news for parents. And so I think what we should be looking at as a profession is what are the things that can go wrong in the mouth associated with mouth breathing, right? Can anyone sort of share with me what some problems may be? What do you see in a mouth breathing child? So you've had older patients who have Sjogren's syndrome, they have decay everywhere, right? So dry mouth is a big thing. What about mouth breathers gingivitis? What about white spots, right? You almost see the lip line. Things you don't get though is ab fracture, right? Bruxism, big and common in mouth breathing, I think. Then, of course, you have the dental side of things where I come in, cross bites, high palates. You have problems associated with sleep. And that's where the link comes in with the whole, how am I concentrating, right? When you're an adult and you don't sleep well, you wake up the next morning and you're lethargic, with lots of cups of coffee. You just can't wait to go home and get your head down, right? Children are the opposite. If they don't sleep well, they become hyperactive, right? So all this lack of concentration, hyperactivity that you see in children is very much related to their sleep. And you as dentists are the first people who are going to pick these signs up. Why? Because we spend more time looking in the oral cavity than any other profession. And if we start looking in the oral cavity on what are some of the medical problems, you'd be amazed that once you've seen it, you'll never unsee it. Does that make sense, right? So my presentation today is really going to be talking about diagnosis, number one, and some forms of treatment, right? So in diagnosis, there's a couple of key factors that I'd like you to include in your medical history. And one is a questionnaire for children. It's called a pediatric sleep questionnaire, PSQ. If you Google it, it's available in something like 90 different languages, and it's 22 questions, right? Parents answer them. If they answer yes to 8 or more, it's a high predictor that the child will have what's called sleep disordered breathing. Doesn't cost you anything, put it in your medical history, but then it makes you focus more on that child, particularly a child who has 10, 12, 13 questions answered yes, right? And that child you'll find will have a history of poor performance at school, possible bruxism, right? Snoring at nighttime, bedwetting, recurrent otitis media, all the things that I'll link in as I said. So a good start is get that sleep questionnaire. All good, right? Second thing is, how are you as a dentist going to manage this problem, right? They're going to have a high caries rate, right? They're going to have problems associated. Let me ask you this. If you have a child who grinds their teeth, who is 6 years old, you can't say a 6-year-old will have the same stress as an adult who has a mortgage in Sydney, for instance, right? With the current thing, or someone from Iran, right? So why would a 6-year-old be grinding their teeth? Any thoughts? Who's had a 6-year-old patient grinding their teeth? And what do you talk to the parent about? Any thoughts? Normal, no, right? If you look at pediatric skulls from the Egyptians even, right? No wear facets. If you look at Aboriginal skulls in Central Australia, no crowding, perfect class 1 room for the wisdom teeth. Does that make sense? So no, it's not actually normal. So what do you think the causes of bruxism would be in a child? Because the parent wants to know. The parent would say something like, look, I've never had an idea my child grinds their teeth because I've never slept to my child since they were 1. They sleep in a bedroom down the corridor. But we went camping or we went on holiday, we had to share a room together. Oh my God, I could not sleep because my kid's doing this all night long. Who's had that sort of conversation starter? And then what do you say? Most common is large adenoids and tonsils, where bone comes in, right? What about the second thing? That's one of the side effects, right? Because if you're bruxing, right, that's a motor disorder like sleepwalking or sleep talking, right, or restless leg syndrome. So definitely it disrupts your sleep cycle, so you don't get to deep sleep, right? So very good. So basically, the kid is in what's called a sympathetic overdrive. You understand? Cortisol, adrenaline, right? Dogs sharpen their teeth just before they're about to bite you. So the human response of doing this is a flight or flight response. And for many children, it's airway obstruction. Secondly, gastric reflux, right? Third is very common in a condition called restless leg syndrome, which is low iron, right? And then you go right down the list, there's things like parasites, etc., right? But the bottom line is it's not normal for a child to brux. It's not normal for a child to snore. So let's start with that. And if you ask those conversations with your parents, most of them will say, look, I don't know because the kid doesn't sleep there, right? So you look in the mouth, you give the questionnaire, then you can really probe the questions. So if I ask the parent, does your child snore? How could I confirm if they snore? Any thoughts? I'm just not going to stay awake all night and wait and listen to them. How could I confirm they snore? I could send them for a very expensive pediatric sleep study, which is $1,000, and sometimes a 2-year waiting list, depending on if you want to go private or public. But what's a common way I can check snoring? An app, yeah. There's so many apps. The best one is Snore Lab. Why? It's free and it's very accurate. So if you download it on any smartphone, you can leave it 1 night, 2 nights, 3 nights, and it averages the sound that they're making, right? So that's what I suggest to the parent. I say, look, I think your child has some sort of breathing. Why? The questionnaire shows a high positive return. Secondly, I can see wear on their teeth, right? And then I ask questions like, how's your kid sleep? That's why my kid sleeps terribly. I put him down there, he tosses and turns, he sweats, and he's down there by the end of it. That's restless sleep. These are things we're looking for. Make sense, right? So this is the chap who taught me all about sleep. So I have a postgraduate degree in orthodontics. I have a postgraduate degree in dentofacial orthopedics, and I have a postgraduate degree in sleep medicine, right? And that combination, I think, allows me to look at things slightly differently. Now, I trained in Glasgow, where you're from, right? I had many good nights in what was then the Royal Infirmary, right? And back then, I knew nothing about airway. So I did a 3-year postgrad degree in orthodontics, and I learned how to move teeth, right? And unfortunately, I didn't really understand what was causing the crowding, but we treated the symptom, not the cause. What was the symptom? No room. How do we treat it? Pulled out 4 teeth. Well, in Glasgow, many were already missing anyway from all the pub fights and everything else. And then all I had to do is put braces on and basically do this, right? Now that I understand that the position of the tongue and the room for the tongue is so important, I hardly extract teeth anymore, right? Maybe wisdom teeth, but certainly not premolars. Whereas when I trained, my extraction rate was maybe 90%. So that's one point of difference, right? So this guy, his name's Christian Gubino. I studied under him when I was at Stanford University. And that is the home of sleep medicine. And Christian Gubino is known for many things, but the term AH, which is the way you measure sleep, is his baby. But before he passed away, he said, I wish I didn't come up with these figures because people now treat to the numbers, not to the actual cause of the problem. And what he said is the most important thing in sleep, and he was a researcher for 50 years, right? He was actually a psychologist who then went back and did further training because he saw problems in children associated with their behavior was all sleep related. And what he said is the most important thing for a child is to be able to breathe through their nose. That is the most important thing. Now, welcome to Australia, where most of the people don't belong here unless you're Aboriginal. So every second kid has an allergy. Who would agree? Yes or no? Most kids I know are allergic to their shadow, right? But Melbourne is the allergy capital of the world, isn't it? Right? The flora and the fauna you have here. And at 10% of kid who doesn't have an allergy, in Melbourne, there's a good chance you're going to break your nose. Yes or no? Fell, whatever. So that's why this guy is so busy. Yes or no? So whatever the cause of the poor nasal breathing problem is, we see the symptoms. The palate doesn't develop properly. Can anyone tell me the link? Why would a palate be narrow in a mouth breather versus a nasal breather that mouth is closed and their tongue's on the palate? Any thoughts? Exactly. Yeah, if you look at how it grows via intramembranous ossification. What does that mean? That the sutures of the maxilla don't have any inherent growth potential. So people like Murray Meikle in New Zealand, Dutulu, etc., they all did experiments where they took sutures, put them in a Petri dish, put them in an animal model, and they realized there's no inherent growth potential of the sutures. What do you think causes maxilla to grow? 2 things, nasal breathing and proper tongue posture. The tongue hitting the palate and the sinuses developing downward, what causes the muzzle effect, is what causes the maxilla to grow this way and that way. So a good-looking face with no crowding, with plenty of room, teeth will also have plenty of room for the tongue. Does that make sense? But look at kids you see today. How many times do you see a perfect arch form and the tongue sits perfectly? So one thing I'm going to teach you to do is what's called a suction hold. You basically get the kid to lift their tongue on the palate and you see if the tongue sits within the molars or outside the molars. Does that make sense? If the tongue sits over the molars, you'll see scalloping on the side of the tongue, and that tells you straight away that kid's arch form is too narrow. And if we take out teeth to resolve the symptom, we're going to worsen the problem. And the tongue is going to have less room, going to go further back, worsen the child's sleep disordered breathing till they get the worst part of sleep disordered breathing, which is sleep apnea. Does that kind of make sense, right? So I have a passion, now that I understand sleep, of really protecting the airway, right? Now, I'm not a general dentist. I can't pick and choose when I see patients, right? You as general dentists can have conversation starters with your parents about the kids' sleep and their behavior and their grinding and link it back to their narrow jaw. That's, I think, a very important sort of take-home message, right? So give you a copy of all these slides. If you want to take a photo of that QR code, you just need to my staff an email. I'm also going to send you a couple of chapters from textbooks. I did my in sleep medicine. The Bible was a textbook, Essentials of Sleep Medicine by Kruger. And the latest Kruger actually has dental chapters, right? I want you to read those so you understand everything I'm talking about is very evidence-based. You may not be exposed to it because it's not common type of things, right? I'll give you the textbook chapters. I'll give you some of the classical articles, including my PhD research. I looked at who had apnea, and I looked at what type of malocclusions they had, and we correlated, was there a link between a certain type of jaw structure and sleep disordered breathing, right? Any thoughts on that? What type of jaw do you think would be more prone to poor breathing? Would be a class 3, a class 1? Yeah, 2, right? But a class 2 where the mandible is retrognathic, or a class 3 where the maxilla is retrognathic, or the most common kid, which is 100% going to have sleep apnea, where both jaws are retrognathic, what we call biskeletal retrusive, right? And by 7, you know where the maxilla should be. Why? Because this part of the skull, called the anterior cranial base, it stops growing by 7. So once you know that's set, you know where the maxilla should be and the mandible should be. And the maxilla grows very early. So most maxillary growth is finished by 8 or 9. Do you understand? Right? So if you've got a narrow maxilla, you can't wait till the orthodontic age of 13, 14 because you've missed the boat. Does that make sense? Right? Yeah. You know why? I think because it's doing that feed. Is it? I go right next to it. I'll stand on this side then. Okay, basically, I want to talk about normal breathing versus breathing. So normal breathing, your mouth is closed and you breathe through your nose. Does that make sense, right? Now, so some parents, they may not get that. And sometimes I say, look, if your child is eating their lunch by putting food through their nose, would you be worried? Yes or no? That's not normal, right? Yet I'm saying, are you worried that your child is breathing through their mouth? And they say, well, I thought that's normal. My husband does it. He snores. You know, actually not normal. If you just Google search with mouth breathing, reason we don't want to mouth breathe because all the air that we breathe that goes through the nose gets humiditized, it gets filtered. We have nasal hair, right? But if you open your mouth, what's going to happen? All that germ-laden air goes straight through here. And of course, your defense mechanism, your adenoids and tonsils enlarge. So the question is, should we be treating the mouth breathing cause or just constantly looking at the large tonsils and adenoids, right? So that's always debatable, and Ryan will share more information on that. Normal breathing, try that. You popped it over? Yeah. Just this one? Yeah. Okay. So normal breathing, air goes through your nose. It gets filtered through your turbinates. It goes down to the back of the nose, what's called the nasopharynx, where the adenoids are. And then it goes vertical down to the lung, right? So we as dentists or orthodontists, we take lots of x-rays, CBC or lateral cysts. We can actually see, laser pointer on there or not? We can actually see where obstruction may occur, right? So one adjunct, rather than the ear, nose and throat doctor putting a nasal endoscope is our radiology, right? How many of you take CBC as a routine X-ray? I was worried to do CBCTs because of radiation exposure, but if you collimate your machine, a whole head X-ray that shows me the airway and I can reconstruct an OPG and a lateral ceph is less radiation than one OPG. Does that make sense? So it's actually the opposite. If you're taking an OPG for your patient, it's two-dimensional, it's highly inaccurate, right? Why wouldn't you take a CBCT? And if you take a CBCT, you can really look at the airway well. Make sense, right? So talk about bruxism, right? And answer to your question, good answer. Bruxism for dentists is a bad thing. You don't want to, $40,000 full mouth reconstruction that then wears down the veneers, yes or no? That's the worst thing to dentists, right? Guess what? For medical people who understand this, bruxism, right? Hyperactive mesenteric activity is the body's defense mechanism to sleep apnea. Why? When you grind, right? Maybe your teeth are not even in contact, but your masseters are overworking, right? So it's called rhythmic masseter muscle activity. And that triggers the tongue to get out of the palate, out of the back of the throat. You understand, right? So if you look at this study, what did they do? They had normal patients who didn't have sleep apnea, but they them to increase CO2, what we call hypercapnia. And what do you think when you have hypercapnia, when you're with oxygen, what happened? You masseter activity. And masseter activity triggers the muscles that move the tongue out of the way, and the big muscle there is the genioglossus. So it's very interesting. If you speak to someone in sleep medicine about hyperactivity, they know that that's normal and it's an early sign, a warning sign of sleep apnea. Yet what do we do? If someone's a bruxer as an adult, what do we do? Any thoughts? We give them a splint. And does the splint actually stop them grinding? No, they grind through their splint. So really, it's like I'm here hitting my head against the wall, and you come over and give me a pillow. That's the equivalent of your splint. Yes or no? Right? Now, the reason I want you to be aware of this, last year, massive lawsuit. What was the lawsuit about? A dentist had a patient who was grinding. They made them a upper arch hard acrylic. Yes or no? Most of you do the same. Correct? This patient then 6 months later went to their medical doctor because of poor sleep. The medical doctor got a sleep study. The sleep study shows they have confirmed sleep apnea. But the sleep apnea is what we call moderate, right? So under 30 episodes per hour. The sleep physician, who's quite clever, says, listen, because it's moderate, rather than me put you on CPAP, which I know is not very long-term, people don't wear it and it's uncomfortable, you can't travel, I'm going to send you this dentist who knows what they're doing, and they're going to make you an appliance at night to do what? Hold your jaw forward so your tongue doesn't collapse. Make sense? Right. And the patient goes, well, hang on a minute, I just paid $2,000 for a dental splint. And unfortunately, the sleep physician said, well, the splint he's made you worse than your apnea because it's making less room for your tongue. That's probably not a good thing to say, right? But it gets better. Patient goes back, goes to the dentist, I want my money back because you made me the wrong splint, you misdiagnosed. But now the dentist should have just written a check, yes or no, or rung you. Is that right? Yeah. Dentist puts his and say, look, this is what I do for all my patients. You're crazy, you're mental, that's why you grind your teeth, all the wrong things. Patient litigates. And of course, it's indefensible because the sleep study shows sleep apnea. Yeah. Then they did the sleep study with the splint in and the apnea worsened. Does that make sense? So you can't defend that. Yeah. Now, I won't tell you what the settlement is, but it was one of the biggest settlements. So what does that tell you? Maybe next time you're about to give a flat plane splint or put Botox in the muscle, both of those are going to worsen sleep apnea. So you think you're helping the patient, you're worsening the condition. And now that the lawyers have this as precedent, watch out because they're waiting for this. Does that make sense? Right? So what should that dentist have done? What should you do when you have a patient who grinds, who snores? Get a sleep study. And the sleep study shows sleep bruxism. The treatment is totally different to stress-induced bruxism. There is still stress-induced bruxism, but that will occur in a different stage of sleep. It'll occur in REM sleep, dream sleep. So you have a bad day, you don't like your work, you don't like your marriage. Of course, you're going to act out this sort of function. Do you understand? Yeah. And they don't even need a splint. What do they need? psychological counseling? Yes or no? So I'd hate to tell you this, all the splints you do are a total waste of time and money. I shouldn't say that. Do you make a lot of splints with, won't be invited back here again, will I, right? Yeah. Do you understand what I'm saying? Yet when I went to dental school, guess what? All we knew, anyone who grinds a teeth is just going to splint. Are we treating the cause or the symptom? And are we improving the symptom? No, it's crazy. Yes.
Suggesting that anyone that you see that has bruxism or nocturnal bruxism, we should consider ask some questions about sleeping.
Correct.
If there's
A high return in score. So for children, well, I'm talking about children today, your sleep questionnaire. Adults, Epworth Sleep Scale. Where from? Epworth Hospital, right here in Victoria. World famous research, right? So Epworth Sleep Scale also tells you, so if you have a high score on SS, right, and you see wear facets, 100% you need a sleep study. Okay. Now, most of you won't know how to interpret a sleep study, nor will you know how to order a proper sleep study. A proper sleep study for a dentist is not putting electrodes here to measure restless leg syndrome. What muscles do you think I want to measure in a sleep study? Masseter? So temporalis?
Yeah.
Not too much of that white wine. That's not good. Yeah. Temporalis? Yes. Masseter and here. Why do I want to measure this muscle? Because what I've just told you. And straight away, you can see the microarousal triggering the hyperactivity. Do you understand? Yeah. So if you order a proper sleep study, you can actually help the patient. I'm not saying you won't business. You probably need to make them a mandibular splint, and that's going to help their airway. Do you understand? Yes or no? So what he does for me, if I get a sleep study that comes back with patient bruxes, but I send them to him, what does he do? He nasal endoscopes, and as he's looking at the airway, he asks them to bring the jaw forward, right? And if the airway opens up, I know I have 100% successful outcome. How does that sound? Even before I take my, for the appliance. Make sense? And the more and more you realize, particularly in children, their wear facets are where? On their anterior teeth. Because what are they doing? They're protecting their airway. You get a little child who bruxes, bring their front incisors together. They meet so perfectly, even you with your diamond burr couldn't get that anatomy that good. Do you understand? They are protecting their airway. So the wake-up call is a child who bruxes is not due to stress. An adult who bruxes may be due to stress, but you can't just assume that for everyone. Does that make sense? And I'm going to give you all the references, and I'm hoping you're going to read the chapters in the textbooks, right? So my PhD was all on this, right? I looked at nearly 4,000 children who had sleep apnea. We did sleep studies for all these kids. And then I realized certain malocclusions were more common. And then we started doing different treatments. And I looked at what gave the best results. So the sad thing is, not one treatment gives 100% success. If I send it to him and he takes out T's and A's, that doesn't mean the apnea goes away. It reduces. If I widen the jaw, if I make them a mandibular appliance to bring the jaw forward, that improves, but it doesn't 100% fix. Do you understand? Why? Because it's multidisciplinary. And the multidisciplinary is all about getting the arch correct, putting the tongue in the right position, yes, making sure the nose is clear for breathing, and then the most important thing, which is called oral myology, which he understands because I didn't realize you did a training in oral myology. And oral myology is like physiotherapy for the face. If you've had a major operation, a knee reconstruction, what happens after surgery? You need physio. You need the muscles to work again. Exact same. If a child can't breathe through their nose, mouth breathes for 9 years, he does the T's and A's, they need to learn how to breathe through their nose again. Do you understand? So the most successful outcomes we got in our PhD research were kids who we sorted out their airway, we enlarged their jaw structures, made room for their tongue, and we rehabilitated their muscles via oral myology. Does that make sense? So the more you get into this, the more you realize you're part of a key. You as a dentist can't treat it all, but you can help diagnose it. That's the important thing. All good? All right. This shows you, data I was talking about. Look at Australia. We're a world leader in a lot of things, but it's not good to be the world leader in ADHD, or we have the highest suicide than any other country in the world, nearly double the next country. Did you know that? Yeah. Why do you think we have the highest suicide rate for teenagers? We're the lucky country. People are not starving. It's all to do with sleep cycles, right? If you've had a teenager, who all look too young, you don't, except for you. And have you had kids? Oh, too young. Kids, my youngest is 30, right? Yeah. Didn't know why some animals eat their young until my kids were teenagers. Oh my God, you could kill them, yes or no, right? I tend to stay well up past their bedtime, yes or no? And they're always on some form of, I always say, what was it? iPod, wasn't it the first thing? iPod, iPhone. For me, iPay. That was, I remember. And the kids was always like, Dad, all of those things, well past your bedtime, they stuff up your brainwave activity. Do you understand that? So behind your eye is a gland called the pineal gland, and it controls your melatonin, serotonin. So caveman didn't have electric light, right? When it got dark, guess what? There wasn't a lot to do. He fell asleep. How did he wake up? The light went through the cave that had no door, and he woke up. Do you understand? Perfect circadian rhythm. In Australia, we've lost that. And the teenagers in particular, they have to go to school at a certain time, but they go to bed later and later. Do you understand? And that blue wave affects their brainwave activity, so they don't get to deep sleep. Now, night, that's going to catch up. Do you understand? Yeah. So it's really interesting. If you want to learn more, if you go to the Doc Institute in the University of Sydney, they study teenage depression and et cetera. It's quite sad. I'm an orthodontist. I would say twice a year, I get a phone call from my mum. Quite sad. They say, look, won't be coming for any appointments anymore because you committed suicide. Or I've had to go to the morgue and take the braces off a kid because they want to, present the kid without the. It's just terrible, right? And it's more and more common. I'm sure in your career that you will experience that, right? And why we need to, as dentists, I think we save teeth, but are we saving lives? Does that make sense? And picking up a kid who has sleep disordered breathing because you've picked up the bruxism and all the other symptoms and helping them to get better sleep and better concentration and do well in class is just so much better than anything you'll ever do in dentistry, right? Like us as Australia, great statistics for. Have you heard of NDIS? How many people do you think in Australia are on NDIS? 1 in 7 Australians are currently on NDIS. You reckon that's that kid who's not paying attention in class because they're not getting oxygen to their brain? They're never going to really contribute back to society. Do you understand? So I think it's a deeper calling to understand this. Now, don't believe what I'm saying. I want you to read it yourself. This is the textbook, right? Kruger, of Sleep Medicine. The book is that thick. In fact, I always recommend it if you have insomnia. Just start reading chapter 1, and by chapter 3, you'll be fast asleep. And when I did my master's, they examine any chapter. So I had to understand narcolepsy, insomnia, restless leg syndrome. Do you understand? But for you, I'm going to make it easy. I want you just to read section 18. First time in this history of this textbook, 7th edition, where they realize dentists need to be part of this team. Really good. Thank God, right? You probably don't realize how important you are in this sphere, but they get it already. So in section 18, they're going to talk about your role, adults and children. For children, it's all about modification of their skeletal structure. As Ali will tell you, if a kid is like that, and I can do this while they're still growing, I open up their airway. Make sense? Did you know that if I expand the palate by even 1 millimeter, it increases airflow to the radius of 4? That's a huge return on investment. Huge. Make sense? But many of you see kids who have a high palate, who have purple at the base of the palate, not pink, who have venous pooling here. You understand? Who can't? Yeah? Who have disorders, right? I know when I was a dentist, any kid that was not manageable, we'd take out the prescription pad for the pediatric dentist. Yes or no? Right? Does Smiles Group have a full-time pediatric dentist? No. Well, let me just share with you, pediatric dentists don't like kids either, particularly kids you send to them. What does pediatric dentist have that you don't have? General anesthesia. But why don't you ask yourself, I had a kid today, came in for a consult, right? He's 6 years old. He doesn't sit in the chair. He slides up and down the chair. Then he starts hanging by the operatory light. And the mum's like, she's heavily dosed on Valium because she's had to deal with this kid for 7 years. And I'm looking at this kid and I'm saying, this kid is not normal. Why do you think the kid's not normal? Poor sleep. Give the mum the questionnaire. Do you understand? Right? Look in the mouth. What do I see? Tonsils that are kissing. A tongue tie. Yeah. And because he bruxes, right? Tongue tie means the tongue's not sitting there. Of course, that kid is a walking disaster. Yet he's been seeing a dentist for regular checkups. You understand what I'm trying to say? So I think start looking a little bit deeper and you start putting, so please read that. And the sleep bruxism, what I told you about, you differentiate between stress-induced bruxism and sleep bruxism. I'm not talking about awake bruxism. Awake bruxism is a different animal altogether. The correct term for awake bruxism is clenching. Clenching means you see someone in Sydney traffic and they're doing like this, yeah. Airway, that is stress. And if you tell people your teeth should not be together the whole day other than for 15 minutes when you swallow, your teeth touch tongue, and you tell them, fridge, put a sticker on your workstation, put a sticker, and when you look at the sticker, see if your teeth are together. If they're together, you're doing something wrong. That treats the problem. Do you understand? It's easy to treat awake clenching. The nighttime parafunction is much harder. Got it? But you'll find it all goes back to this airway. So please read these chapters I'm going to give you. And please understand there's a big link between the types of jaw patterns you see and sleep disordered breathing, right? This is a great podcast if you want to take a photo of that. This is an orthodontist from the US. He runs free podcast and it's called the Doc Podcast. And they interviewed me in episode 33, where I talk all about this, right? I want you to read my PhD, published in a tier 1. Hardly no one else in Australia has ever been published in this journal, actually. This was 15 years of research. It's talking about the facial patterns that lead to sleep apnea, and also the second part, what treatment options. So when I take a CBCT, why do I take a CBCT? Less radiation than an OPG, and I get to look at the airway. I get to see where the obstruction is. Now, I'm not an ear, nose, and throat doctor, so I'm not going to tell the patient that I'm going to remove their tonsils, right? That's for him to do. But at least I can say, based on your pediatric sleep questionnaire, based on your narrow palate, worn down teeth, fracture, I'm going to suggest this may be a cause, or turbinates, or deviated septum, or, so it allows me to understand that when I went to ortho school, and remember, I went to a top tier orthodontic. I went to the Eastman in London, right? And the Eastman is you don't have an undergraduate, it's just pure postgraduate. Eastman, I did 3 years, graduate as an orthodontist. I didn't have one lecture on any of this. In fact, in the UK, the only patients we saw were people who had been on the waiting list on the National Health. So by the time their name came up, they were already year 7, year 8, year 9. So we'd lost the ability to change any jaw position, size, structure. Yeah. What I used to do a lot of those patients is I had a lot of impacted canines, I had 10 millimeters, and I was taught in the Eastman that if you have 5 millimeters of crowding, you need to take out premolar teeth. Understand? And that was my training. I was lucky enough to be exposed to a from Europe. His name was Linda Aronson. And he did all his research on breathing and development of the jaw. And then I realized, you know what? This is the symptom. The cause is the narrow maxilla. What causes the maxilla to be narrow? What I told you, lower tongue position. Do you understand? So if I take it all the way back here, what is true preventive orthodontics? Maybe in Melbourne, it's to prevent the patient from going to another practice. Yes or no? Right? It's quite competitive here in Melbourne, I know this. But, but in Melbourne, it's a race to the bottom. Everyone's offering aligners. Do you think aligners will anyway improve your airway? Not at all, right? So to me, I have like a unique selling point. I want kids early so I can assess their breathing, their sleep, and their jaw dimension. Do you understand? So I can open 100 practices in one township where there's already 10,000 orthodontists. But guess what? No one else is doing this, which is a shame for my profession. So what I'm saying is I'm focusing on this, and so should you. Because in dentistry, you're going to see all those patients who have the worst dentition related to some of the symptoms. And how many of you see an adult patient who grinds their teeth? Come on, like second patient, yes or no? But you ever ask the question, or what do you do? Let me ask this lady, right? Where do you work? Where? Warren? I have no idea where that is, huh? West side of Geelong. Wow, that's like the way. Did you need a visa to get here? West side of Geelong. Geelong itself is the other side of the water. And you're west of that, where all the fires and all were, right? Isn't it? Yeah, well, welcome. I'll stamp your visa as you go home. Okay, you go to work tomorrow. right? And the first adult you see for their 6-monthly checkup, right? You look in their mouth and you realize, oh my God, all their lower incisors are totally knackered and they're only 30. You're doing that, right? Now, you ask the patient, do you grind your teeth? And what are they going to say? No. So you don't even ask that question. Self-reported bruxism, less than 5% accuracy. So don't ask the question, yes or no. What would I be asking? Do you find, it's called stop bang, right? I ask, do you snore? Do you get tired easily? Lunch on most days, do you feel you want to have a snooze? How many Red Bulls do you have? How many times in the morning? What do you have? Oh, I have double espresso. If not, I'm telling you early signs. Do you know what I'm saying? And then maybe before you treat the symptom, you look at the cause. How does that sound? Right? I'd highly recommend, particularly in Victoria, company called Arise Home Sleep Studies, right? It's run by a dentist. His partner is a sleep physician. And thank God, for years we've been pushing the Australian Sleep Association to allow home studies for children. From 1st of July, that's going to happen. Otherwise, it's really hard to get a kid, particularly in Victoria. There's only 1 or 2 sleep centres. There's a huge waiting list, right? Yeah. But for kids, if you see the problem, ear, nose and throat first. For adults, you see the problem, sleep study first. It's a very different treatment. Adults, different symptoms to children, right? But it's a big thing. When you come to your, called in Sydney, huh? When you come to Inspire, you in particular, why?
It inspires, sadly not for every practice.
Why?
You could ask our chief executive that.
All right. Well, Chris.
Yeah.
Oh, is it for high performing practices?
Yes.
Well, hopefully they'll tape it. And my lecture there is all about adults. Here, I want to go back on the kid thing before, but it's very common. Okay, so that's the $1 million question, isn't it? Right? The thing is, there's a difference between bulk bill and Medicare subsidized. So Medicare subsidized means it's not free. Right? In fact, one thing I always say to people, when the government gives you something, it's not free. You're paying for it. Do you understand? Yeah. Yes, these are Medicare approved. Why? They're a level 2 study, which means Medicare approves them. Yeah. They're not 100% free. If you want 100% free, you have to go to a public hospital in a sleep unit. And good luck, the waiting list, you'll probably die of sleep apnea before the number comes up, right? Yeah. You tell me, Ryan, when you want to sort of hop in. This is my guru, and a lot of the papers I'm going to give you, in fact, even in the textbook, are written by her. This is Audrey Yoon. Audrey was a pediatric dentist, right? And then she realized all these problems the kids were having. So she thought, fix this. Then she became an orthodontist, right? After becoming an orthodontist, she went back and did sleep medicine. And that's where I met her at Stanford. So she's triple qualified, yeah? This is probably the best paper to make you understand on treatment. I've given you a little bit about diagnosis, but then once you're diagnosed, what are you going to do? And in this paper, she road maps what to do at different ages. I would never dream of expanding a 5-year-old when I went to ortho school. We never saw a 5-year-old. I'd laugh if you said, got a 5-year-old booked in for a consult. Why is 5 an important age to help the airway? Any thoughts? How many of you see 5-year-olds? Yeah. What should a perfect dentition look like at 5? Gaps between every tooth. Yes or no? When's the last time you saw a kid with perfect gaps, class 1, tongue sitting on the palate? Not in Australia. Why? Because in Australia, most kids aren't breastfed for long, and they've gone straight onto the bottle, straight onto the pacifier, which causes poor tongue posture, narrowing of, you understand? If I ever, reinvent the wheel, I'd open no gaps orthodontics. Now for you, you think the parents say, oh, that's great, it's free. But no, health fund, no gap or something. Yeah. Gaps mean your kid has no gaps, whereas they should look like that. Yes or no? And then I give them a sleep questionnaire. I expand routinely at 4 and 5. If the kid can cooperate, it's so easy. Why? Expansion occurs like a month. It's bang, right? I expand to scissor bite. You understand what that means? And the kid has to bring their jaw forward to function. And they do, right? Now, why else is that important? What do you think the brain stops growing? When it's not needed. Well, in Australia, that's from day 1, isn't it? Yes, the brain stops its development by 5. So if you're not getting oxygen to your brain from 0 to 5, you'll never recover. You'll be in the bottom of your class for the rest of your life. Does that make sense? So if I get a kid, I don't go looking for 5-year-olds to expand their jaw. Do you understand? But if they come in, bruxism, bedwetting, large adenoids and tonsils, you understand? Poor sleep, I look at the palate, it's like that. Yeah. Examining the kid, it's like being next to Darth Vader. You're like, of course I'm going to expand the jaw. Why wouldn't you? The question is, do I send it to him first? Do I expand first? And what do I do after I expand? Does that make sense? So what I do is I take a CBCT, I see there's massive obstruction. I know where the major cause is going to be, I send it to him. After he does whatever he does, then I widen the jaw and we train the tongue to sit on the palate. Does that make sense? And guess what? I've been doing this for so long now. You see this beautiful jaw develop. Make sense? And the parents thank you. They say, Dr. Mahony, you're the first one that picked up my kid snoring. Now my kid's doing so well at school. I really, make sense? Yes or no? Whereas when I was a dentist, I never got thank you letters for the root canal that I did, maybe a lawyer's letter. I'll tell you the truth, I only did one root canal ever in my 40 years in clinical practice, one. And I created an extra canal, MB3, right? So, I do is not even hard, you know what I'm saying? Yeah. You do like wisdom teeth and root canal, that like takes skill, right? To me, it's just all about looking in the mouth, diagnosing. Anyone with their eyes closed can fit an expander, yes or no? How many of you know how to fit an expander? Only Ali. Well, maybe you should be running a PSG, is that what it's called? Pacific Smile Surgery, PSG seminar. Because once you realize every second kid has a narrow jaw, you're going to have to then do what? I haven't got time to treat everyone, right? But you, at the primary source giver, should expand. And it's easy. You can't go wrong. The suture's wide open. All right. So when you get to the older people, that's when you should refer, because at that stage, the suture is not amenable to expansion. So what do I have to do? I have to put TADs in the palate. That's more skill. But for you, the young ones, right, from 0 to 9, perfect. Now, how do I measure if a kid needs expansion? Little kid, I'm looking at no gaps. I'm looking at poor tongue posture. I'm looking at high palate, cross bite. What other things would tell me? Any thoughts? Deep bite actually gets better when the premolars erupt. So I wouldn't treat just for a deep bite. Very good, right? What else? Well, believe it or not, if you look at the research by Dr. Maurice, Harvard University, he looked at children from birth till 18. And he retrospectively looked at kids who had beautiful jaws, no crowding. And he worked backwards to see what was the commonality. Guess what the commonality was? The intermolar distance, yes, was about 38 millimeters on average. Greater than that, even more room for wisdom teeth, right? So if you get a cotton roll, believe it or not, every cotton roll in the world is the same dimension. Did you know that? 37 millimeters. So if you get a cotton roll and you shove it between the first molars and it doesn't fit, Houston, we may have a problem, just as a guide. But I don't want you to cheat. There's accurate softwares. And when you read that chapter, it'll show you how you can determine what the size of the jaw should be. But what do? I just get the patient lift the tongue. And when the tongue sits over the teeth, right? What else did this research show? Maurice, that after 7, the intermolar distance doesn't increase in life. Did you know that? So when you get a mum who says, my kid's only 7, their jaw's still growing, what are you worried about? I know that the intermolar distance at 7 is set for life. The cranial base, set for life. Did you know that? Read the research, right? Harvard University, the dentition, Conrad Maurice paper. And then you realize how so many of the kids you see are presenting for crowding when you could have intercepted the crowding early. You understand? So learn how to do a model analysis, right? Nowadays, you just scan and the computer does it for you. I use, what's that? Medit. Yeah, and Medit have an automatic free arch analysis. So with one scan, I can see what's going on. Medit's the only company that also measures the palatal depth, because this is important. The higher the depth, the narrower the width, the more airway. Makes sense, doesn't it? Less chance of the tongue hitting there. But how many of you are measuring width and height in your patients? None, because we're not taught how to do that. Make sense? If you are probably, what's that probe? You go digging for gold. This is I remember you had a mirror, a probe, and a tweezer. And if you're lucky, a perio probe. But the one that scratches, and if it sticks, there's mad. Not a perio probe, the explorer. Yes, exploring fish. Yeah. Meanwhile, they're lying in your chair while you're fish sealing the deciduous molar, whatever the hell, right? So rather than patient taking bite wings, right? Look at the bigger picture. There will be a day, I reckon, who's going to ADX, the big meeting? Yeah. Watch the new CBCTs. They're accurate enough just to look at decay. So you can get one X-ray, look at airway, look at the palate, and check for decay. How good is that? Okay, so sleep breathing. Do you think it's common in children? Yes or no? Absolutely. And look at the stats. These are Australian statistics, right? A child who snores 4 times more likely to be in the bottom 25% of the class. How many of you ask, does your child snore? How many of you have kids yourself? Do you want your kids to be in the bottom 25% of the class? Absolutely not. Now, wait, a child with sleep apnea. So let me explain to you snoring and sleep apnea. I'll dental it for you. If you have incipient lesion, that means it's not past the enamel. I get a migraine when I think of dentistry, right? But then you don't do anything. You let the kid not floss, eat lots of sugar, mouth breathe, and then it goes all the way into the pulp. Yes or no? The decay never started in the pulp, correct? It started here, but you weren't monitoring it. Same thing, mouth breathing, primary snoring, upper airway resistance, hyperventilation syndrome, then sleep apnea. So sleep apnea is the worst part of the condition because it hasn't been picked up early. Does that make sense? But all the research is only on sleep apnea, whereas it should be more on just the preventive stuff. So a child with sleep apnea, 9 times more likely to be in the bottom 10% of the class. And you can repeat that kid 1 year, 2 years, 3 years, they'll still recover. Why? They've missed the opportunity for oxygenation of the brain. Do you get it? So this is what you'll see in these kids. You'll see grinding, snoring, hyperactivity, bedwetting, and you'll see the really severe malocclusions. Anything where the maxilla or the mandible are retronating. So her second paper then talks about how to treat, right? Paper 1, what to look for. Paper 2, how to treat. Please read these papers. You may not read the chapters textbook, but you've got to read these papers. And these papers will help you understand how you can do some early stuff, even if you don't get involved in treatment. I want you to treat. I don't want you just to diagnose and keep referring. I want you to understand it's very simple to expand, right? And if you expand properly, which is what's called not expansion, rapid that, we do what's called semi-rapid. Semi-rapid drops down, the airflow improves. Okay, so it's easier to do semi-rapid expansion in mixed dentition. That's what you should be doing. Not for every kid, but for children who have airway problems. Now, most of you would only think about expansion in a crossbite. Who would agree? When I went to ortho school, we'd never expand unless the kid had a functional shift, like, yeah. But you'll see a kid where all their lower teeth lean in. Do you understand? So nature is compensated for the narrow palate. They don't have a crossbite, but they have a high palate. That's the ones people miss. So what I'll go through in future lectures, because I think how long timing? So I'm doing half and you're doing half. What time is it now? 7:47. Oh my God, I've gone, oh, sorry. All right. I'll introduce Ryan, right? But basically, you could just read Audrey Yoon's 2 papers. And if you're really enthused, read the dental section of the textbook, chapter 18. I'll download all that to you just on the Q code. Yeah. And really, when you start looking, so all I want you to do, so take home message, yeah. For children, I want everyone to get a pediatric sleep questionnaire. Doesn't cost you anything. Secondly, I've got a checklist there. It's called Zagi 6 flags. And it tells you how to measure the palatal width, how to look for certain symptoms. And if the 6 flags come back high and the pediatric sleep questionnaire comes back high, I think that kid needs further investigation.